So I'm Alyssa Stephenson-Famy, as Dr. Taubman said. I've done this a few times, and every time I actually try to update the slides so that we have a little bit more kind of context. I actually think that 2015 was a very interesting year for publications on opioids in pregnancy, neonatal abstinence syndrome, and so I think that the kind of punchline of today's talk is stay tuned, because I actually think that there's beginning to be more and more data in various directions, and I think that there are probably going to be some changes in guidelines, maybe over the next few years. But I put in some new data from 2015 and even some publications from this month, last month. So these are the general disclosures of this program. Here is my talk, which is really more about opioids than pain. We could talk about pain in pregnancy for maybe like 8 hours, and I think that that's probably too much for this very brief, targeted session. More to do about opioids today. I'm a state employee, just like everybody here, and so I have no disclosures or conflicts of any kind. So the objectives for this talk, and again, this is what I will emphasize over and over, is that really the whole point of this is to avoid using opioids in pregnancy, and really avoid using it at any point in pregnancy, even before someone is actually pregnant, because this is turning into, there's more and more data coming out about potential issues of opioids in pregnancy, such that it would be great just to not use them in reproductive age women at all. We'll describe some of the risks of opioids in pregnancy, and then discuss the potential role of taper detoxification. Again, this is probably actually where the data is the weakest, and where clinical practices actually move beyond some of the existing data. So there is a variety of different strategies that you could use to approach pain in pregnancy, and this, again, should be the hallmark is don't use opioids if at all possible, and really try to use an expansive repertoire of other non-pharmacologic approaches. Lumbopelvic pain is extremely common in pregnancy, and it's probably the classic pain paradigm, especially when people have pre-existing injuries. They are often exacerbated by pregnancy. People have acute pain issues in pregnancy, and this is probably, I think, one of the more common reasons that people might be tempted to issue an opioid prescription during pregnancy. And so there's some low to moderate quality evidence for use of all of these things, but I think that patients really appreciate sometimes just throwing the kitchen sink of other non-pharmacologic remedies at them, specifically because of the potential risks. Non-pharmacologic therapies are actually more diverse than just acupressure and osteopathic manipulation. I think that there's a lot of people who bring a lot of additional psychosocial contributors to pain, which pregnancy exacerbates both pain and psychosocial stressors. So if at any point in time you can identify a patient who's actually having really pain as a manifestation of a psychiatric condition, social stressor, or as evidence of intimate partner violence, that is something absolutely to identify right off the bat, so that you are not going down this, like, I'm going to put a Band-Aid with treating pain, when really pain is like the tip of the iceberg, and you really need to get in deep, have social work see the patient, refer the patient into counseling, and get the patient the help that they need. In terms of non-opioid pharmacotherapies, this is the real problem, is we don't have a lot of great non-opioid pharmacologic remedies that really are effective or safe. Unfortunately, NSAIDs, which are the hallmark of treatment of a lot of types of musculoskeletal pain, especially outside of pregnancy, in pregnancy are unfortunately contraindicated. In the first trimester, it's not strongly associated with anomalies, but long-term use can be associated with both low fluid, and then in the third trimester specifically, premature closure of the fetal ductus arteriosus is the main concern that we have. Considering an NSAID for an acute treatment course of 48 hours or less may be reasonable for musculoskeletal pain, but I would definitely avoid using this long term. I don't know that patients have this message, and so we will often see patients who have been taking NSAIDs for the first 20 weeks of their pregnancy. Unbeknownst to them, they weren't supposed to. So I would definitely screen for this and make sure that people aren't taking this in an unsupervised fashion. Tylenol is category B, but it doesn't really work. And so I think that we always tell people, take some Tylenol, it'll kind of cure everything. But a lot of patients know that it does. It's not a terribly effective remedy for pain in pregnancy. And so if they don't find it useful, then don't tell them to take it, because I think that there are some other studies that have come out about Tylenol's association with childhood asthma, ADHD, and even autism, and that data is very weak. But the theme in pregnancy is don't use a medication if you can avoid it. The general principles of using opioids in pregnancy is that there are a lot of publications in even the last 1 to 2 years about the very high rates of opioid prescriptions amongst reproductive age women, and this ranges from 28 to 39%, depending on which insurance kind of coverage background the patient has, and then very high rates of pregnant women filling opioid prescriptions, ranging from 21% in Medicaid populations to 10% in the VA system. And we have seen, in general, a full forward increase in rates of opioid prescriptions in pregnant women over the previous decade. And I think this means that we are being a little bit more liberal to use opioids. Maybe we're, as providers, less, we're crunched with time and the patients have lots of demands. We feel like this is an easy Band-Aid without a lot of risk. But I would very strongly suggest that we should put a firm limit when it comes to opioids and not get liberal like we have in non-pregnant populations. I actually just read a really interesting article about how women with opioid addiction are actually very, very poor contraception users and have very high rates of unwanted pregnancies. And so this is a particularly important problem because if someone has opioid addiction and becomes pregnant either on illegal opioids or methadone therapy, we need to be aware of that because those patients statistically are apparently more likely to become pregnant. So in pregnancy, there are many physiologic changes that occur, and this occurs with an increased volume and distribution, change in the protein binding, both hepatic and renal kind of clearance and metabolism both are on the rise. So for chronic opioid users, the kind of counterintuitive thing is that they actually might need more by the end of pregnancy because of these physiologic changes to keep them out of withdrawal. Anesthesia in these patients is very challenging for people who are on large amounts of chronic opioids as an outpatient during pregnancy. We need to be very just aware of their anesthesia-related issues, a lot more complicated if they require a C-section. So the teratogenicity data, I think, is actually getting more complicated since I last gave this talk in June. And there was a recent study, actually just in November, that was a Danish population-based study that showed about a doubling of rates of congenital anomalies for opioid-exposed pregnancies to non-opioid-exposed. And this included women who are on heroin, methadone, or buprenorphine. And so I think that there's been a lot of increase in these epidemiology-based studies over the last few years, and although ACOG, their practice bulletin says there's no clear pattern of teratogenicity, and that's still my party line with patients, I think we may see more data over the next few years that suggests that we should really be avoiding opioids in the first trimester for this specific reason. In terms of adverse outcomes, there's a whole bunch of studies that show this, including a most recent one from 2015. And the associations during pregnancy with opioid use are preterm delivery, poor fetal growth, and these are incredibly confounded studies by all of the comorbidities. And really, this most recent study from 2015 showed that tobacco was one of the main confounding agents, so that when patients were on opioids and used tobaccos, they had all these outcomes. Tobacco is very highly associated with these outcomes in general. So I think that it's hard to really say that patients who are on chronic opioids in a stable maintenance program are going to necessarily have these outcomes, but the data would suggest that we should be surveying them more closely. In terms of neonatal abstinence syndrome, previously, the reported incidence was kind of in the 30 to 90% range, and there's been a little bit better studies that have looked at larger kind of confirmed population-based studies where they actually looked at more than just ICD-9 codes, and the rates may be lower than this, and in some populations they could be higher. So I think that this range is kind of appropriately large because we really don't have a great prediction model for which babies will develop neonatal abstinence syndrome. The symptoms can be quite significant, including irritability and tremulousness, all the way to potential onset of seizures. And then the postnatal Finnegan score is what grades the degree of the irritability, vasomotor, and GI disturbances, and what kind of tips off the pediatric staff after the baby is born that the baby actually needs to either undergo more observation time or actually treatment for neonatal abstinence syndrome. Short-acting opioids have much lower rates of neonatal abstinence syndrome and earlier onset, but that can occur anywhere from the first 24 hours of life to day 14 of life, and with the peak at about 72 hours. A lot of data has looked at maternal dosages of opioids in pregnancy and neonatal abstinence syndrome. And with methadone specifically, there's not an exact one-to-one correlation that if someone's on 100 milligrams of methadone, that's going to relate to a 80% probability of NAS versus 10 milligrams results to a 10% risk. It's not that linear, it's not that straightforward, but there is a general trend towards higher rates of NAS with higher doses. And buprenorphine has very consistently in all of the studies showed a much lower incidence and shorter duration of NAS, maybe more in the kind of 10 to 20% range. There's some really interesting work being done on predictors of neonatal abstinence syndrome, and I think this is one area to kind of stay tuned. We're looking at some really fascinating genetic contributors, and perhaps the people who have genetic susceptibility to, adults who have genetic susceptibility to addiction may pass on some of those traits to the fetus, who is then more susceptible to neonatal abstinence syndrome. And so I think that we will see some really interesting data looking at kind of both kind of this like tailored genetic medicine versus epigenetic modification that occurs in utero for some things like the mu opioid receptor. I think that these things may give us some insight into why NAS occurs for some babies versus others. There are some interesting maternal risk factors, and this includes things like any other substance or alcohol abuse, smoking, and SSRI associations. And I'm not sure if SSRI is really causative for NAS or just a lot of babies are also having SSRI withdrawal, which looks a lot like NAS, may have irritability and some of that psychomotor irritation. So stay tuned. Maybe in a future talk we'll have some more information about this. But opioids and lactation, the American Academy of Pediatrics supports the use of breastfeeding in women who are on any sort of legal form of opioid, but not illegal form. So women who are abusing heroin are not supposed to breastfeed. And again, some of the opioid dose will get into breast milk, and this may actually be a kind of mild form of treatment for babies who have NAS. So there's no risk to babies who are exposed to otherwise like healthy moms, say who get a C-section and go home on short-term opioids. There's no risk that that amount of opioids that's received in breast milk will lead to some of the opioid side effects like sedation. So if opioids are not ideal in pregnancy for lots of reasons. Clearly there are first trimester risks. There are risks for adverse pregnancy outcomes. There's this big looming risk of neonatal abstinence syndrome. Then really, like, should patients be taking them at all? First of all, try to avoid using them in really any women who is at risk for being pregnant, which is anything basically from the age of like 9 to 50. With the realistic, time frame of reproductive age is about kind of this. The studies always say like 15 to 44 as being the kind of target range. But if you do have a woman who enters pregnancy on opioids, what should you do? And ideally, we'd love to minimize the overall maternal and fetal opioid exposure long term. We do not want to have women have a lot of opioids in their pocket and really reduce the risk of overdose and diversion. And then we ideally would like to reduce the risk of kind of all of the complications we just talked about. So there's some really old, not very good data that associated opioid withdrawal or detoxification in pregnancy with risks of preterm labor, fetal distress, stillbirth, miscarriage. And these are the types of concerns that are continuously raised in kind of the old textbook version that says that we really should not taper people off opioids in pregnancy, and kind of the old adage has just been like maintain, keep people out of withdrawal and maintain. Now, women who are on methadone, it's kind of a different story because we kind of want them to stay in their methadone maintenance programs because we really don't want them to quit using methadone, then go back and use heroin. Heroin is clearly a suboptimal supplement, so it's not like recidivism and converting back to their old risk-exposing behaviors is a good idea. So methadone maintenance programs are good for a reason. It's ideal, again, if people weren't on them at the beginning of pregnancy, but like stopping people from methadone or in pregnancy is probably not the best plan when they have a true addiction history. Now, in terms of women who are on kind of different types of opioids, so say you have a woman who just is on, kind of has chronic back pain, is taking some, Vicodin a day, 4 tablets of Vicodin a day. It would be ideal if she could maybe not take that during pregnancy. If you can figure out how to try to get her off of it, and again, that's unlikely to produce withdrawal, that probably will overall reduce the long-term risks of the NAS and some of those other associated risks. So tapering someone off low-dose, short-acting medications is probably not a terrible idea. But the high doses, you may be able to taper down on the dose, but you don't want to put the person at risk for illegal behaviors. So there have been a few studies, and this is where I do think clinical practice has kind of moved beyond the data. There's a few not fantastic studies looking at inpatient detoxification, and then a couple of studies looking at an outpatient detoxification, and they're really not robust. In general, most of these are done on inpatients because of the risks we talked about, the kind of historical risk of associated kind of preterm birth and stillbirth and fetal distress, that if you're going to detox someone off their opioids, you may want to do it in an inpatient setting. And again, there were 3 different studies that looked at this, and there was about a 60% successful detox rate. There's one brand new paper it's a Canadian outpatient paper, and it was a really interesting study, a very small community where they really had geographically super isolated, and they were able to kind of have people under this very specific supervised daily outpatient doses of I believe it was a long-acting morphine, but it was not a methadone program. And they actually had 87% of patients were able to taper significantly on their dose, but only 9% were able to quit. And so I think that trying to do whatever we can to minimize the overall dose and risk makes sense, but getting people off kind of cold turkey may be really challenging, except if you have a robust, supportive inpatient environment where people can actually get off whatever they were on, and then build some real strategies and kind of behavioral approaches to their previous addiction history that might prevent them from reusing again. So in conclusion, I just cannot emphasize enough, the data is getting just soupy enough about potential risks during pregnancy that if you can have a patient get off her opioids before becoming pregnant, that is the best possible situation. And then really avoid at all costs initiating opioids during pregnancy because of the known fetal and neonatal risks and complications. If you need to initiate them, I do think that it requires now some counseling about the fact that we do have a little bit of very mixed teratogenicity data. We have all this kind of adverse pregnancy outcome data, all epidemiologic studies, but still no less kind of valid for consideration. And then if you have someone on chronic high doses, considering an anesthesia and a pediatric consult to talk about the approach to NAS for this baby once it's born. So with that.
Wow, great talk, huge amount of material, and yes, it was new data. I really
There's a little bit in a whole bunch of publications in 2015, which is interesting. Yeah.